how genetics can support you and actually help you in case of a particular type of pregnancy or a subset of pregnancies, which we all have come to know as precious pregnancies. So quickly to talk about who we are and what's our philosophy. Essentially, we are a company involved with genetic testing and services, but we like to partner with clinicians and their patients by empowering them to make better decisions using our test results and support. So simply put, what our entire motto and operating philosophy is help us to help you to help them. Right? And we do offer a broad range of tests, and they cover a wide spectrum. In terms of what we are talking about today, we offer preconception testing. We also offer pre-implantation testing for IVF pregnancies. We offer prenatal testing, and of course, neonatal and adult testing is also involved. So what are precious pregnancies? Now, what happened is when I went through this and looked at the term, there were a wide variety of definitions. And let us be very honest here, for any parent, any pregnancy is precious. Only in terms of medical fraternity and us as geneticists, some tend to be more precious than others in terms of the effort taken and the time taken. In fact, when you're going through the examples which I'm talking about today, you will see that a single case has a very, very lengthy time. And for the doctors on today's webinar who have dealt with these precious pregnancies, we are not talking about months. We could even be talking about years. In fact, the longest running case for me, which is even currently active right now, is over 4 years. So I am working with a couple from over 4 years to achieve success. And that is a case where it is an IVF pregnancy with both PGS and PGD. So these are long-term things, and this adds more weightage to that term precious. So essentially, it's broadly defined as any pregnancy which is established after multiple attempts or using ART techniques. So this could be ART, so they need not always be IVF pregnancies, right? Generally, there's a lot of failure or poor obstetric history involved in this, and there could be even pregnancy losses which are recurrent. So there are very often precautions taken for such pregnancies. There may be some additional changes in medication, some other regimen, and even doctors may not want to prescribe too much of invasive testing. So fortunately today, some of the tests we are going to be talking about, which is non-invasive, can help you very much in such pregnancies as well. Right? Some of the risk factors commonly associated with these type of pregnancies are AMA, advanced maternal age, gestational complications such as hypertension and diabetes. You have also complications where there's multiple gestations, the fetus does not develop properly, you have growth retardation, so on and so forth. And of course, the ever-present genetic issues. When there is positive family history, poor obstetric history which is associated with genetic abnormalities, and whenever you have earlier pregnancies which are positive or earlier children who are positive for a genetic disorder, this always adds to the risk. Right. So we'll get to preconception testing. This is of course done before the pregnancy is established, and generally this is done for both the parents, or if they're going for an IVF route or an IUI route, it is done with a parent and a donor. Please remember, whenever we talk about this carrier screening, we strongly recommend that it be done in pairs, both parents or a parent and a donor, because this is a comparative analysis. So we look at two different profiles and compare them together. So we also, apologies for that, we also offer a combination screening, which I'll get to shortly, but our very own NGS couple show panel has 1500 plus recessive genes, because predominantly what you're looking for are recessive conditions like the ones listed below: albinism, thalassemia, cystic fibrosis. Can somebody unmute themselves and tell me what is a recessive condition, a recessive genetic condition? Quickly, please. Anyone on the call can tell me what is a recessive condition?
Recessive, hello?
Yeah, please go ahead.
Recessive conditions are those conditions which manifest when both the alleles on both the homologous chromosomes are defective.
Wonderful, thank you so much. So essentially what happens is all of us have two copies of most of our genes, right? And the recessive conditions are those where both need to be abnormal for it to actually manifest. Thank you so much. So generally when we're talking about carrier screening or a service provider talks about carrier screening, they're pretty much exclusively talking about recessive conditions. So what happens is not all the common conditions, things like even beta thalassemia, DMD and spinomuscular atrophy and Fragile X, all are not going to be having great results from NGS alone. So we often say that it's better to combine NGS selectively with non-NGS based methods such as Sanger, MLPA, which is a PCR based method, and of course repeat expansion analysis. So what happens is when you give this preconception to the parents, they understand, okay, in the fetus this is what the risk we have to assess for, or these are the particular variants we need to look for in the fetus, and what is the risk of recurrence. Because please remember, genetic testing's major unique feature is that it's one of the few tests which can give clinicians a tool to analyze risk of recurrence. Very few other tests can offer it. In fact, it's almost exclusively genetic testing which tells you risk of recurrence. Right? So whom can we prescribe carrier screening or donor screening for? Generally it can be used routinely in IVF centers. In fact, we have a few clients in India who routinely send us samples saying that, look, these are my donors, these are the couples who are coming, we would like to do carrier screening here. There is some family history, we would like to do it. Remember, carrier screening is being recommended for asymptomatic people or asymptomatic carriers. So these people are not going to be affected, but they may have an affected child or an affected family member. So we have a case here, very interestingly. This is a male who was one of the parents, and the doctor said, okay Sam, I'm not going to be able to give you the donor sample right now for comparison, but at least do his sample. And then they said go for MLPA for spinomuscular atrophy and go for NGS and see what you find. So the MLPA, luckily for him, came negative. But interestingly, the NGS test, remember the 1500 genes with 2000 plus disorders, that did come positive. And what were our findings in this case? Interestingly, he was a carrier for a likely pathogenic and a pathogenic variant. So for those of you who are not familiar with this kind of table or this kind of report, the first column talks about what is the name of the gene. This is a reference number which is associated with this gene on a website called OMIM. It's a very good database for looking at genetic disorders. What is the type of disease and what is the inheritance? Remember, we just spoke about autosomal recessive. What is recessive? So AR here stands for autosomal recessive. Which is the part of the particular gene which is getting altered? What is the exact change in the DNA? So you can see from here it is G getting changed to A. Similarly, it's A getting changed to T. Is there any change in the protein sequence or amino acid sequence? What is the zygosity? So here again, very important, you can see that this individual, this male, is a carrier for both. So he would not be affected. But if his partner or donor is also a carrier for a mutation in the same gene, please remember, it is mutation in the same gene, it need not be the same mutation. So if they are also carriers, when they are having a child, there is a 1 in 4 or 25% chance that the child would turn out affected. And here he has two particular disorders which are manifesting independent of each other. So each of them has 25% chance of, each of them has 25% chance of completely manifesting the child or the child being affected. So here what we did, we basically counseled them that look, for this we need to screen the donor also, the oocyte donor in this case, and that sample is being arranged for us for testing. So this is how you would do it. Typically, if you had the couple, what I would have here along with this would be the female profile also alongside, saying that, okay, look, this particular gene, let us take the first one, IQCB1. This particular male has this mutation, the female has this mutation. So again, this is something we need to screen the fetus for. However, again, looking at IQCB1, sorry, if only the male had it or only this sample has it but the female does not have it, we need not screen the fetus for it. So doing this in preconception stage helps us filter out a lot of unnecessary things and determine the significant variants to be screened in the fetus. So before I get to PGS, I hope everyone is kind of getting some clarity on carrier screening. This is also called donor screening when you're looking at a donor, whether it's a sperm donor or an egg donor. This can also be done. Important takeaway notice, it's always recommended to do this in pairs, one female and one male, so that you get a comparative analysis right away. Sometimes we understand that in India, the parents might not be available, the donor might not be available at the same time. So we understand we do one after the other, but typically or ideally, we would like to do both together and give you a comparison right then and there. There are any doubts regarding this, you can let me know. In addition to this, we offer fertility genetic screening. I'm not talking about that today. If anybody is interested, I can share that separately. There are n number of profiles for this, including things like premature ovarian failure and things like thrombophilia panels. We do have that. So those can also be tested pre-conception in cases where it's required and there are certain issues in fertility. So if there are no doubts, I will proceed further. We have completed with the preconception stage of the talk and we are going to the pre-implantation part of it. So if there are no doubts here, I will continue. I'll take a 1 minute quick break. If there are any things which are coming to mind, you can message me or you can unmute yourself and ask me. Thank you. Oh, I'm sorry, for those who cannot see the presentation, I would be sharing the presentation anyway after my talk, and the video also would be uploaded by Yogesh. So both of that is available. I do request that you please have a look at it and you can always reach out to us. Again, since I'm going to be taking a break, I'll try to start sharing my screen. If that works, then this problem should be overcome. If there are no other doubts, may I proceed? Again, you can ask me anything, even a simple doubt. If you're not understanding any terminology, so on and so forth, you can always stop me and ask. I would be happy to explain things, right? So with everyone's permission, I'll proceed. Next, we are talking about pre-implantation genetic screening. And of course, everyone is familiar with this. I'm sure you must have heard of PGS or what is called PGTA. This is essentially an aneuploidies screening test. It's a confirmatory test for IVF embryos. So the embryos which are produced through IVF, specifically through ICSI, this is a very, very useful tool because as most of you are aware, the success rate in IVF is highly variable and tends to be low and tends to change from patient to patient, center to center, protocol to protocol. One of the major drawbacks is the successful implantation of an IVF generated embryo can be quite low, and even if everything is perfectly done in the lab, it still could have some genetic defect which prevents it from implanting or implants, and by 6 to 8 weeks you just get a weak heartbeat in the fetus which disappears. So this is something most IVF clinicians will experience in their labs. So we have a test here wherein you take a few cells from the embryo and you selectively test them on NGS, next generation sequencing, and you see the chromosome number in them and you're able to report, look, this particular embryo is suitable for transfer whereas the other one is not. Let me elaborate. So before we get into a case, what we are offering currently at Eurofins is the Reprocessing ion torrent system, We offer 2 megabase resolution. That means we are able to catch quite small changes in the chromosome as well. It need not always be an entire chromosome number changing, not always a monosomy or a trisomy. It could be partial as well. That means part of the chromosome is gained or lost. We are able to pick that up. We are able to predict mosaics. What do we mean by mosaics? Very often in IVF embryos, not all cells will be abnormal or aneuploid. Some of them would have perfect chromosome number. You would have all your 23 pairs there, but some of the cells would be having some trisomy or monosomy. And very often the decision whether you want to transfer an embryo which is having mosaic aneuploidy comes down to the percentage of cells or the percentage of cells showing the mosaic. So that is very important. That is a useful tool for guiding. Additionally, we are able to give you mitoscore, wherein sometimes even if the embryo is euploid or having the right chromosome number, if it is under metabolic stress, what the cell does as a defense mechanism or a compensatory mechanism is it produces more mitochondria. And of course, mitochondria has its own circular DNA, right? So if the cell is under stress and it produces more mitochondria as a compensatory mechanism, you will get more copies of the mitochondrial DNA. Generally, these kind of embryos also will fail to implant or have poor pregnancy outcomes. So this is an additional parameter to be considered once you are looking at the euploid embryos. So you have two choices for doing the biopsy. You can do it on day 3, which is the cleavage stage, or day 5, which is the blastocyst stage. We recommend the day 5 biopsy because it's very, very informative for us. It is quite safe. It is less traumatic to the embryo. And also what happens, we are able to detect and predict the mosaicism about which we just spoke. Because if you look at it, the day 3 embryo typically has 8 to 10 cells. The large big cells you're seeing on the top image, that is a day 3 embryo. And that is quite easy for the embryologist to remove a cell, but in one cell you're not going to get information on mosaicism. And imagine if the embryologist has sampled the one cell which is normal and the other 1 or 2 were abnormal and they were missed, this report would come as normal, but when you transfer the embryo, most likely it will fail. And vice versa, if unfortunately the cell which was pipetted was abnormal and the others, out of those 8 or 10 cells, the other 9 were normal, the report would come as abnormal, and then we would discard an embryo which possibly had good potential for implantation and probably would result in a good pregnancy outcome. So we strongly recommend doing a day 5 biopsy. However, it's a little tricky to do a day 5 biopsy. The cells are quite sticky and you need a very, very skilled embryologist to do the day 5 biopsy. They should be trained in doing day 5 biopsies. That is quite important. What are some of the requirements if you are planning to do PGS and PGD in your center? You need the PCPNDT license. You require a laser assisted biopsy system because you want to hatch the embryo. Some people do laser assisted hatching for day 5. As well as doing the actual biopsy, you need a laser guided system. You need a very skilled embryologist who can comfortably not just do biopsy but post biopsy tubing. This is very important for all the clinicians on today's call and all the embryologists on today's call, because very often people are trained to do biopsy, but where they actually lose out is when they're doing what is the process post biopsy known as tubing. Tubing involves sequentially washing the biopsied cells in different types of buffer and then collecting them and storing them in a centrifuge tube, in a microcentrifuge tube or an Eppendorf tube, right? Very often if this step is not done properly or if some of the cells are lost, what happens? We are working with only 5 to 10 cells typically in the day 5 biopsy. If they get lost or they lyse, then your entire result goes. Very often you will get a revert from us or your service provider saying no DNA identified, possibly cell lysis has occurred. So again, I think a lot of progress has happened in the past decade over this. There are a lot of wonderful sessions which are held throughout the year by various organizations like ACE and others. ACE, ISAR, all of them do a lot of this work. I think that's really beneficial because this is the overall rate limiting step here, in that if your embryologist does a good biopsy, does the good tubing, 90% of the time you will get a result. Okay, this is in my experience. So of course I've been working in this for the last 4-5 years. So this is my experience in this. And is this PGS really necessary? There was a lot of debate, I think a few years back, saying that look, some European study has come out, we have ESHRE data which says the study is not good, so on and so forth. And I got flooded overnight with a whole bunch of calls on this from various IVF clinicians saying, Sam, look at this particular study, this study done in Italy, and it's really not showing any benefits of PGS. But understand, today we're talking about a day 5 blastocyst biopsy. That particular study was done on a very primitive type of biopsy known as a polar body biopsy. Right? So that was a very primitive data because Italy has a lot of restrictions in doing pre-implantation testing and prenatal testing. So they had to do the study in that way. But you can ask any one of your patients who has had a successful embryo transfer with PGS, and then you will understand the value to you. Because for you, each pregnancy is a precious pregnancy, and each successful pregnancy is a great success for both you, the clinician, as well as your patient. I would just like to step away from the presentation a moment and share my personal experience. We had a couple who had literally gone around the world. So we had a couple who started off in the UK, and she had difficulty conceiving naturally. So they went for IUI. I think 2 to 3 cycles of IUI failed. She was in UK. She tried IVF. 1 cycle there, it failed. They went to Australia, they went to Monash, one of the leading hospitals and centers for infertility treatment. They did IVF there, 2 cycles, it failed. They are Indian, so this process has taken years. It's not a few months journey, this is. So IVF, 2 IVF cycles failed in Monash. They belong to South India, so they end up in Chennai, Madras here, and they come to a center. And we are working with that center as genetic testing providers. So imagine this entire thing now started off sometime back, and after 10 plus years, they ended up in Chennai saying that, okay, look, let us give it one final shot, one attempt to let us see. If not, we'll look at alternatives, right? So we counsel them and they say, okay, look, we have tried everything else. Let's do IVF with PGS and see what happens. So we get 6 embryos, out of which 3 turn out to be euploid, 3 are aneuploid. And this particular center transfers a single euploid embryo. So please remember, this is the first IVF cycle they have done with PGS. And the outcome is implantation, good pregnancy outcome, healthy child. So for that couple, these statistics are very different from what they want. So that's why each precious pregnancy is a world unto itself. Right? And for that couple, imagine 12 years they have tried. They have started off in UK, literally gone around the world, all the way to Australia, and they found their answer in India, in Chennai. So this is the kind of examples and experience I have. I do have examples of the other side also, but this is what I mean when we talk about, is the technique useful or not? This definitely helps the patients. And this is not just me saying it, there's a lot of literature in support of this. Right? In fact, it's very much required, especially when there's advanced maternal age. And I think everybody on the call would agree that couples are planning to start or trying to start families at a much older age than before. Most of them would have crossed 35. And of course, what happens, I need not tell, is the risk of downs goes up, the oocyte quality drops, the reserve itself can come down, so on and so forth. But does PGS really impact pregnancy rates? The answer is a resounding yes. If you look at 2 data, Dr. Fiorentino, who is also part of the Eurofins network, in 2014 published a paper, and even in Sir Gangaram Hospital, along with Abha and Gaurav Mujumdar, along with Dr. I.C. Verma, they have published a paper where you can see that when the couples undergoing IVF also opted for PGS, there's almost a close to 30% increase in the implantation rates and successful pregnancy outcomes. So that is quite a significant difference, and that is going to add value to your services and to even your success rate in IVF. So that is something important I want you to consider, and think about when you want to see if you want to do PGS or not. Right, this is a typical PGS result. Do not get overwhelmed by it. I'll explain it in detail. So what you're seeing on the left hand column is the sample ID. What you're seeing there is the embryo ID. And what you're seeing on the right hand side after that, 1 to 22 X and Y, is essentially the chromosome number. So this is just for a case, of course. This will not be the actual result, where we would not be showing X and Y. If there are any abnormalities, we'll just say sex chromosome aneuploidies. But for today's discussion purposes, I've kept this data. And to the right of that, you see a particular column saying mitoscore, right? So the mitoscore is the one where I talked about for euploid or normal embryos. You would look at the mitoscore as an additional parameter, where you are going to say that, okay, if the mitoscore is too high, I don't want to transfer this will not be my first choice, right? And if you look next to that, we actually give the transfer recommendations, whether it's going to be the PGS 17, where you can see yes, PGS 18, which is no, PGS 20 again, which is no, and the others are all yes. So let us look at these two cases, PGS 18 and PGS 20, which are two of them where we are saying no. So what happens here is both are different and both are going to be not recommended by us, but as clinicians you may consider one of these two as a backup. Very interesting. Let me explain a little more. So this is the first one where you have trisomy 6, right? You can see trisomy 6 here. So trisomy 6 here, you can see this particular thing. This thing is called a copy number variation or CNV chart. You should get this as part of your report. It's important because then you can help your clinicians make more informed choices when they look at this, right? You're seeing this particular range over here. Anything which touches the upper line is a trisomy. Anything which touches the bottom line is a monosomy, and everything in between is 2 copies, right? As you can see here, for chromosome number 6, the entire region has 3 copies. So the entire chromosome 6, 3 numbers are present. This is definitely not going to be recommended for transfer, right? Even if all of them are aneuploid, you would say no, still I don't want to consider this. What do I mean by if all of them are aneuploid? Let's look at the next case. This is monosomy 15. So monosomy here, again, what's happening? You are looking at chromosome 15 here. There is a loss of chromosome 15, the complete chromosome, right? But remember what I talked about, those lines about monosomy, trisomy and disomy. This is not a complete monosomy, is it? So let's assume this is 10 cells. Not all the cells seem to have only 1 copy of chromosome 15. If you can look at the chart, you will see what I mean. So you can see that it has not come all the way down to that bottom line. So this is what you call a mosaic monosomy. So here again, chromosome 15, you can see that we have labeled it as M, not a plus or a minus. So this is a mosaic. So again, like I said, an important guideline for clinicians would be what percentage mosaicism. So it is generally acceptable that 20 to 80% mosaicism can be considered. This is according to the PGD Society. But in India, general rule of thumb is anything above 50% is disregarded. But please note, your service provider, even with 20%, will very often tell you that this is not recommended. Because what should not happen is, they should not use this as the first choice if there are other embryos. So very often you will get not recommended for this, even though it can be considered for transfer if there are no other good embryos. Right, I'll be moving to prenatal next. So I've done with preconception. If there are any doubts or queries, you can ask me. If there's anything you would like me to repeat, please let me know.
Hello, Sam. Uh, Hello, can you hear me?
Please go ahead.
Yeah, as you have already mentioned about this, mostly PGS is recommended for advanced maternal age. But what's your experience also about severe male factor or recurrent implantation or recurrent miscarriage? Uh, where a lot of data is also not available, I think, right? Especially with severe male factor for PGS,
Okay, excellent
specifically
question.
on
Thank you
that
so much, Jimmy.
population.
So, for me, if you look at severe male factor and RIF, implantation failure cases, PGS is good. PGS gives you a lot of insight into the quality of the embryo being formed. RPLs are a bit more tricky because pregnancy losses can happen, first trimester, early second trimester. So there they tend to be more tricky. So PGS is a better solution for cases where you have male factor, severe male factor, and also where you are having your recurrent implantation failure cases. RPLs, yeah. So RPLs, it would be a little bit more tricky. It would be a lot more dependent on whether we are finding aneuploidies in the POC or whether you're finding actual chromosomal abnormalities in the POC and at what resolution. What I mean by that is, are we looking at entire chromosome number changes? Are we looking at microdeletions, duplications? Depending on that, PGS would be more useful. Dr. Deepa has asked a question that what is your experience with mosaicism and outcome of pregnancy? What cutoff has been successful in your experience? Like I said, Dr. Deepa, generally, if it is 10 to 20%, it's pretty safe. But again, if you have a true euploid embryo, you will not look at a mosaic. So in a situation where I have very often come across, couples are not having a large number of embryos to start off with. So they may have 1 or 2 embryos only. And in that case, we will counsel them that look, you have 2 choices. You can go for 1 more cycle where you can get some more embryos, or if you say no, I'm not ready to go for 1 more cycle, we would transfer this embryo. This would be the kind of risk for it. Are you willing to consent for the same? So sometimes patients, if they're not willing to undergo 1 more cycle, will say no problem, doctor, we will try with this, we understand, we give our consent. So it's a mixed bag. I would say it is more when if you have low percentage, below 50%, generally you find that the success rate would be, among those which get implanted versus non-implanted. What I have seen is almost a 60-40 ratio. So mosaics do implant, especially mosaics around 20%. More than 50%, of course, the risk will go up significantly. In India, generally, we see even doctors quite averse to consider embryos above 50%. Below 50%, they are okay, but above, no. Yes, so let's say they are BRCA positive. Yes, doctor. So Dr. Ganesh has asked, can it be used to screen for autosomal dominant disorders? Absolutely. So when you're talking about PGD, that is exclusively for IVF embryos again, and that can be used for recessive, dominant, X-linked, recessive, X-linked dominant disorders, anything it can be used for. In fact, quite interestingly, PGD, there's a clinical trial on PGD for BRCA patients, because BRCA patients, before they go for chemo, will very often be recommended, at least abroad, and I think in India also to a large extent, to preserve their oocytes. So BRCA is a very good example and a very good, case study for PGD. For carrier screening, generally what you're doing is you're not looking at BRCA, because if somebody is having a BRCA mutation, which is pathogenic, then they're going to manifest. Generally, they're going to manifest. So in the woman, you're going to see this. But of course, if you're looking at some other dominant disorders with incomplete penetrance and you would like us to screen that, that is quite easy to do. So in carrier screening, we generally don't look at dominant disorders, but in PGD, there's no such limit. You can look at recessive and dominant as well. Yes, ma'am. So yeah, we do see that, ma'am. But I also, in my experience, I've seen the opposite as well. Although it's a little rarer when we say that, look, this particular thing is there. Ma'am, actually what happens is when we counsel with the doctors, and generally we work with them to understand that ultimately 2 things happen. One is the patient benefits from PGS. Second, the doctor's success rate goes up. So PGS actually helps. The problem in PGS is the setup. Essentially, you need an embryologist who can do the biopsy, you need the laser assisted hatching system there. Yeah, Dr. Ganesh, so there what happens is you can say the BRCA mutation there, right? You can just say the BRCA mutation, and then you can say that this is a pathogenic mutation which has been identified in this embryo. Since BRCA is not on X and Y, no, it is not that much of a problem. So you can say this mutation is there, this embryo is not recommended for transfer. Yeah, Sakshi, so by and large we recommend using NGS because this is a technical thing, but you have better dynamic scatter on NGS data. So you're able to pick up mosaics much more better in NGS than in microarrays. There is a paper by, I think, Wang et al. In 2015, where he has done the same sample on microarray versus NGS, and you can see the mosaic is very clearly picked up in NGS data. So generally, by and large, your high throughput screens now are NGS. Arrays are available. We are not saying arrays are not available. They're not good, not saying that. But the detection rate for mosaicism is far better in NGS than microarrays. Thank you so much for that interaction. If there are no further doubts, may I continue? Because we'll be going to how this leads to prenatal testing and what are our choices there. My pleasure, Dr. Deepa. Dr. Ganesh, if there's anything, please do let me know. I will try to get back to you on it. Right, coming to the prenatal testing, I think everyone on this call is now aware what is NIPS, not merely because we had a session last week as well, but by and large this is a very, very popular test nowadays for screening of the fetus because it allows you to do it very easily. You don't need to take an invasive sample. You have a very, very robust and sensitive test in NIPS to do a lot of screening for the fetus from the maternal blood. But I think everybody would agree that still this is a screening test. And what are we screening here? It is a non-invasive prenatal screen where you're looking at cell-free fetal DNA or placental DNA, and that is found circulating in the maternal blood, which contains a mixture of both cell-free fetal and cell-free maternal DNA. So where do you prescribe it? Again, AMA is one of the markers. When you have your first trimester or second trimester screens coming as intermediate or high risk for aneuploidies, ultrasound abnormalities indicative of aneuploidies or microdeletions, when you have positive family history, and sometimes even when the patient is anxious. In IVF pregnancies, there's an interesting thing which we always recommend. We have worked with a few centers in Bangalore where they're looking at this and they say, look, Sam, I'm transferring a mosaic embryo. I'm not getting a single euploid embryo. Couple doesn't want to do it. Would NIPS help? In this precious pregnancy, can any NIPS help? So the good answer we have for that is yes. We have certain types of advanced NIPS which we have validated clinically that can be used for detection of these mosaic embryos and whether this mosaicism is continuing in the embryo post-implantation. Fetal fraction is an important parameter which should be there in your NIPS report. I will not go into too much technical discussion. If there are doubts, I will answer them. But generally, you have a 4 to 2% cutoff. And our tests, especially the two advanced tests which I'm talking about today, are validated clinically at 2% cutoff. Be cautious while prescribing for NIPS. Yes, you don't want to prescribe this for T21 positive mothers or mothers who have XXX. So these ones would skew the data, and when the analysis happens, you tend to get false results. So when they are T21 positive or they have XXX mosaics, we don't recommend going for NIPS. Bone marrow recipients, you want to wait for some time, almost 3 weeks plus, and then send it for that. And currently NIPS can only work for up to twin pregnancies. So triplets, quads, NIPS is not a good option. Patients who are on anticoagulants and blood thinners, and I'm not talking about just things like ecospirin or low molecular weight heparin. I'm talking about where you're combining those things with other anticoagulants. There you might want to consider looking at tapering the dose pre-sampling, because what happens is, if you remember my previous slide, I'll just go back quickly to it. It's nothing but a ratio. You can see the ratio here. It is cell-free fetal DNA divided by total cell-free DNA. So what happens if there's a lot of cell lysis in the mother's sample? The maternal cells will start lysing and releasing maternal DNA into the plasma. And once they are releasing it, in that particular ratio, the denominator will go up and the fetal fraction percentage will come down. We call this suppression of fetal fraction. So that happens. So that is something you want to consider. In IVF pregnancies, importantly, vanishing twin is something we must be, always cautious about, because they would have transferred more than one embryo. Both of them would have implanted, and at some point of time, one of the two would have stopped developing, or in this case, would have just disappeared. But remember, even though the embryo has disappeared, that particular vanished twin circulating DNA is going to be available for 6 to 8 weeks. So if you give an NIPS before that, likelihood is you are going to get a false positive for the NIPS. So please remember that for IVF pregnancies, typically 6 weeks to 8 weeks we want you to wait if the twin has vanished before giving it, or always please reach out to us and we can guide you and counsel you on a case-to-case basis. So we have a wide variety of offerings. We have the basic NIPS, which I'm sure I need not discuss too much in detail today. We have the NIPS Plus, which talks about additionally 2 chromosomes and also 5 microdeletions, the most common in the world, including DiGeorge, Prader-Willi, Angelman, Cre-Du-Chat, so on. And also the 2 NIPS offerings I would like to focus more on today for precious pregnancies: the NIPS Carrio, which covers all chromosomes at 10 MB resolution, and the Carrio Plus, which covers all chromosomes at 7 MB resolution and also offers 8 microdeletion analysis. So we have these 2 particular NIPS, and I would like to focus more on them today and how to use them in these kind of precious pregnancies. How do you choose the right type of NIPS? This is a quick summary for a traditional NIPS. You have the standard markers and family history, but if you look at the first row itself for prenature Carrio and Carrio Plus, the term there says it all. It is precious pregnancies. And why in precious pregnancies is these 2 forms of NIPS so important is, in addition to the standard offerings of NIPS, they are able to give you what are called rare autosomal aneuploidies as well. Remember that IVF embryo which I showed you, the PGS? Did we get trisomy or monosomy of 13, 18 or 21 in those embryos? No. What was the trisomy we got there? Trisomy 6. Partial monosomy 15. These were the ones we were looking for. And imagine you had taken the partial monosomy 15 case and you had transferred it. These 2 NIPS would give you a good, strong, robust option for screening that non-invasively. So that is why I would like to go more in detail for these 2 types of NIPS in the further discussion. So a study which we did with Fiorentino's group in Genoma, we looked at what is the benefit and what exactly we're missing out if we do a routine NIPS. So if you look at a routine NIPS, we missed close to 17% of rare autosomal aneuploidies and other microdeletions. So it is always beneficial to have this with us, and this is an additional choice to you as clinicians depending on the type of pregnancy and what you want to screen. This particular test is available. Coming to microdeletions, a lot of doctors in India will tell you that, look, I don't find any benefit in testing for microdeletions, and ACMG and AOCG don't have specific guidelines. If the fetus is positive for microdeletions, what you have to do. But is it really required? If you look at the chart itself, it's quite interesting. After trisomy 21, if you look at per 100,000 live births, the next most commonly occurring aneuploidy is in fact DiGeorge syndrome type 1. It is the 22q11.2 microdeletion. That itself tells you the impact, right? followed by which you have trisomy 18 and 13. In India, of course, in my experience, the order is reversed. I see more trisomy 13 cases than 18. But interestingly, compared to T13 and T18, which we are so regularly screening, the second most common one after T21, in fact, globally, is diGeorge. And does it have an even bigger role to play? Because initially, before this particular study, which I'm going to share, it was around 1 in 4,000 was the risk. Right? So there was a study by Gross et al. Who specifically looked at the diGeorge microdeletion in an NIPS setting. They studied close to 22,000 samples. And what did they find is, they actually said they had an incidence rate of almost 1 in 1,000. Almost equivalent to your trisomy 21. And what they found is very often diGeorge positive pregnancies would not come to term. It would be quite rare. It would depend on the size of the deletion in 22q11.2. So depending on that, the manifestation and then the continuation of that particular pregnancy would impact that. So this is very important. And Dr. Deepa or Ginny, anyone can tell me what is this compared to T21? What is the risk profile for diGeorge vis-a-vis the mother's age? Can somebody tell me? So what I'm asking in another way I would put it is there an age-related risk for microdeletions? Yeah, Ginny, you're absolutely right. There isn't. So this can happen in somebody who is below 35 years of age as well. So you can get microdeletions like diGeorge, which are quite prevalent in younger individuals as well. So this is something which you should look out for if you're seeing ultrasound abnormalities, if they have histories, if they have somebody in the family who has cardiac abnormalities, having cleft lip, cleft palate. These are some things which you can off the bat recommend, saying that look, we'll not wait for it, let's do an NIPS screen and figure out whether this fetus is having diGeorge. So that also can be done. And these are of course a list of microdeletion syndromes which I just talked about, what is their effect on the lifespan, the neurocognitive deficits, other deficits, and what is the incidence and the sensitivity and specificity, right? So how sensitive is an NIPS test? You're saying, okay, Sam, look, I transferred it's a precious pregnancy, couple has been struggling, finally I got this embryo, it's implanted now, it's developing now. How good is your NIPS? Like how, I'm talking about partial mosaics. Is it really good in catching that? So this is a very interesting case. We had a 31-year-old female who came at 12 weeks to us. She was just anxious and she said, look, I want to screen for, do an NIPS. And what happened was, we got this kind of result. Of course, this is a standard NIPS. I'm just using it as a benchmark for the what kind of things we can pick up in NIPS. So here we had chromosome 13 and it was neither positive nor negative. It was intermediate. If you look at what words are used there, it says chromosome 13, aneuploidies suspected. Result uninterpretable for chromosome 13. So generally what this means is one of two things has happened. That there is mosaicism. This mosaicism can be from the fetus or the mosaicism can be from the placenta. Generally 13, 18, 21 mosaicism you don't get from placenta in my experience. If anybody has some contradictory evidence, please do share it. So here what we said is go for a confirmatory test. Patient opted for doing a fish and karyotype test. In fish, what happened, interestingly, we found a 5% mosaic for trisomy 13. A 5% mosaic for trisomy 13. And of course, when we did the karyotyping, all our metaphases were normal. So the fish test here was able to actually reveal the mosaicism right at the limit of detection of the test. And of course, the karyotypes gave us normal metaphases because it's a very, very low level mosaic. Now, it's a low level mosaic for us. But what about for you, the clinician? What about for the patient? They'll say, boss, low level is all fine, but what is going to happen to my child? Right? So here what happens when we counsel, we say that now this takes a more supportive role and we strongly recommend for going for additional scanning like an advanced fetal anomaly scan or additional biochemical marker assays and look what is happening. Generally, hypothetically, what we can say is the cells with this extra copy are not going to be that good at dividing rapidly and keeping up with normal healthy cells, but we cannot guarantee it. So we strongly recommend going for an ultrasonogram, advanced fetal anomaly scan, which they did. This couple did that, and they found that there was no development of or start of the trisomy 13 associated features. So they continued with the pregnancy. It's continuing. Interestingly, in the same month, I got another case where it was a 10% mosaic. Same path was followed, but they found that the abnormalities were starting to develop in the fetus, and they decided not to continue. So the NIPS test is quite sensitive. Even mosaicism can be detected. Of course, this is a trisomy 13 case. For rare autosomal aneuploidies, the sensitivity would be lower because they are rarer. This is a case where one of our validations along with genoma, we saw a chromosome 7 aneuploidy, and we were able to confirm it through microarray. So even the Karyo Plus and Karyo tests are able to show that they are able to pick up rare autosomal aneuploidies. Interestingly, in Bangalore, I did get a false positive case where I had a chromosome 7 suspected deletion, but luckily for the patient, when we did the microarray confirmation, it came out to be negative. And I was also very happy to give the negative result, although that meant my NIPS gave a false positive there, but I was quite happy to give a negative result, so they could think about it and continue with their pregnancy. So can we kind of arrive at a decision matrix in terms of genetic testing, especially pre-implantation and prenatal, right? And can we try to make a matrix? Of course, this is something which has come up based on my discussion and interaction with various clinicians and geneticists. You are most welcome to give your suggestions to add, remove, or change things, because for me, like I say, every webinar or session is interactive, and I learn as much from you as you do from me. So we're looking here at precious pregnancies. So we're looking predominantly at obstetric and family history, right? And you're looking at the pregnancy type, whether it's natural, IUI, or IVF. And if this precious pregnancy is positive for a history of aneuploidies, and it's an IUI pregnancy or it's a natural pregnancy, you want to look at going at the NIPS Karyo for screening, because you're able to check all the chromosomes. You can recommend the NIPS Karyo. Similarly, if it's a precious pregnancy which is having positive for microdeletions, it could be because of the ultrasound, it could be because a family relative has got somebody who's affected with Dye-George or Angelman, so on and so forth. You can look at the Karyo Plus. Of course, for IVF pregnancies, you're still looking at PGS with or without PGD, depending on what condition you're looking at. And there again, if you are looking at a high risk, then you can again look at a screening using Karyo when it's aneuploidies, and a screening looking at Karyo Plus when you're suspecting microdeletions. Right? Again, so here is the thing. We start off with the family history, the pregnancy type, whether it's IVF and you're doing PGS, and whether it's a natural precious pregnancy or it is an IVF precious pregnancy, you still have both Karyo and Karyo Plus. Remember, these are NIPS for screening of those pregnancies to rule out rare autosomal aneuploidies and rare autosomal aneuploidies with microdeletions respectively. Now, what happens if you get a positive here, or if you say that the Karyo comes high risk for one of the rare autosomal aneuploidies? In both cases, when you get positive results there, you would want to confirm it through microarray. I know I can also offer FISH and karyotyping, but they have certain limitations which I'll touch about later. As a molecular geneticist, I would strongly recommend that all of you consider a microarray as your first point confirmatory testing for any prenatal screens. Even for POC, I would strongly recommend a microarray, because very often you send for karyotyping and FISH, the geneticist will write back to you, cell culture failed, FISH for 5 chromosomes, all 5 chromosomes were normal. So we strongly recommend switching over to microarray. It's become quite cost effective and it's a very good molecular screening method. So So I'm going to just be talking about one example today. I will not discuss too many examples because precious pregnancies tend also to be long drawn out things. Like I said, there's an ongoing case of 4 years with me still. I'm trying to resolve it. So precious pregnancies do tend to do that. So I'll talk about a single case and this will be in multi-steps. So this is our initial analysis. 36-year-old female with no family history has come. That means there's no positive family history. There's no microdeletion, nothing there, but obstetric history is poor. Repeated implantation failure has happened. They're opting for IVF and they're going for IVF here. What is the test we recommend? Any ideas, anyone? What is the test you would recommend here? I'll go back a slide. Yeah. So there is no family history of any microdeletions. There's repeated implantation failure here, right? They're going for IVF, important. Among those tests which I talked about, whether it's carrier screening, whether it's PGS, whether it is NIPS, microarray, which one would you actually recommend? Yes. So since it is an IVF case, yes, you would be recommending PGS here to start with. How did we arrive at this decision? We looked at the obstetric history and family history, pregnancy type. We said, okay, IVF. So we have a pre-implantation screen available. Before we transfer the embryo itself, we can do a screening for aneuploidies. So we opted to recommend PGS PGT-A, which they accepted. And remember the table from earlier? We will pretend that that is the result for this case. But unfortunately, instead of multiple embryos, they only had 4 embryos. Only 4 embryos came. And I have modeled this on an actual case which I had. They had only 4 embryos, right? Out of which you see the first and the fourth one can be recommended for transfer. So you have this kind of, I have just made it easy so that you can stratify them. So for PGS 17 and 22, what will you do? You will recommend it. This will be your first 2 embryos for transfer, whether it is single or double transfer. For PGS 18, you are seeing a trisomy 6, so definitely you're not going to recommend it. But what do we do with PGS 20? This partial monosomy 15 embryo, what do we do with it? So here, what we generally talk to the clinician and the patient, because remember, freezing this extra embryo is going to cost them, right? Freezing this extra embryo is going to be chargeable to them. So what we generally do is we counsel them that this can be stored as a backup. Why? Because even though the embryo is euploid, doesn't mean that 100% euploid, every time you transfer a euploid embryo, it will always implant.
Five.
Right? Is there any questions? Should I take a pause? Should I pause? Okay. Right. So hypothetically, we transferred PGS 17, PGS 22, but implantation did not happen. The patients were counseled, they opted for other IVF cycle. Again, this is based on my experience earlier. In that particular cycle, only 2 embryos are available. And both those embryos are aneuploid. They are not even mosaic aneuploid. They are absolute aneuploids where you cannot transfer them at all. Right? We have a follow-up counseling session and patient opts now to try with PGS 20. Please remember, IVF with a mosaic monosomy 15 embryo. Interestingly enough, where the 2 euploid embryos 17 and 22 failed, this one implanted. What next? What do you recommend next? What would be your decision here? So the answer is NIPS. Can you tell me which type of NIPS you would be recommending? Good. Yes, you can recommend that. Yes, absolutely you can recommend that. You can recommend the Karyo Plus because that does everything the Karyo does along with microdeletions. So yes, absolutely you can recommend that. So let's take a look and see what our decision should be here. So we have PGS 20. What type of embryo is it? It's an embryo with 20% mosaic monosomy 15. So it fits into this particular category in our decision matrix. So you can actually recommend Karyo, but it is not wrong if you recommend Karyo Plus because that does everything this test does along with microdeletions. Remember, this is non-invasive screening. So if this comes positive again, let's say monosomy 15, you're seeing deletion of 15 chromosome, one copy, and you get positive results there, you can always confirm it through an amniotic fluid sample on a microarray. Right? So this is, as you can see, even for a single case, it would take long. And this is something I'm putting up on a PowerPoint. Imagine in real time how long this case would take. We would be probably working with this patient for minimum of 6 months to a year. Right? Because they have cycle after cycle, they're waiting, they're deciding, they're coming back, cycle works, doesn't work, there's a break in between. So 6 months to a year you'd be working with this patient for doing this. And I have patients, like I said, who I'm still working with, it's still trying to resolve. It's a very interesting case. We're trying to find some resolution for that, but this is what happens in precious pregnancies. Every case becomes very, very important. It's a very interesting name, precious pregnancy. I will actually pause here, and this decision matrix and the example I discussed, if there are any questions, queries or doubts, I will take them now. I'll actually pause for a minute. You can type or you can ask me. There are a few questions earlier as well, which I will actually endeavor to answer. Sharon had asked that does NIPT differentiate which twin is actually affected? Unfortunately, Sharon, it cannot, because you're looking at a mixture of cell-free DNA. So the twin origin you cannot make out from NIPS. You can make out whether there is an aneuploidy or not, but from which twin you cannot make out. So Ginny has written that there was a triplet case which got reduced to a twin pregnancy, and whether NIPS can be done for this case. Yes, if it is 6 to 8 weeks after the twin has vanished, or the triplet in this case has vanished and it's become a twin pregnancy, you still can do it. So a triplet reduced to a twin, the twin pregnancy NIPS still can be done, but you need to wait for at least 6 weeks before doing it. And I'm almost at the end of my presentation. So if you have any doubts, you can ask me. So if you have any doubts, you can ask me. Yep.
Actually, I want to ask that. Hello.
Yes, Sakshi, I can hear you. Please go ahead.
If we are implanting euploid embryos, then also it is recommended that we should go for routine screening and amniocentesis.
So if you are implanting euploid embryos, they're successfully implanted and the pregnancy is progressing, your standard scans, double marker, NT, everything will happen. Your routine pregnancy scans will happen.
So, and what about the amniocentesis?
No. If it is required only, you will go for that invasive test. If you say that, see, what we are checking for in PGS, chromosomal abnormalities. So God forbid this case, the child is having a mutation which causes a syndrome called Denny-Drash syndrome. Right? There you would have oligohydramnios because it's a kidney malfunction there. And there you would find abnormalities there. Then you would want to go for an amniotic fluid sampling, and probably you would want to go for an NGS panel for testing.
If there is nothing abnormality, if it is a routine pregnancy which is going very well.
You need not go for an invasive test unless it is indicated. You need not go for additional genetic screening test unless it is indicated.
So that means that PGS is 100%.
Yes,
I mean, it is 100%.
PGS is 100% in terms of what it tells you about the cells. Now, what could happen very rarely is that the cell, all the 10 cells, 15 cells you have sampled in your day 5 embryo,
Hmm.
All of them are normal. Some other cells somewhere else are abnormal and they now manifest. So the likelihood that that would happen in your embryo itself is extremely low.
Yes, sir.
Where this happens and more likely to happen, Sakshi, is when you're working with day 3 embryos.
Yes, yes.
And the implantation rate in day 3 itself is too poor. Because
Okay.
you're only taking one cell, so the likelihood you'll miss an abnormal cell is more.
Okay.
So in my
Thank you.
experience, I have not seen a case where we have transferred a euploid embryo, it has implanted, pregnancy has progressed, and later on we have found some aneuploidy. I have not come across it. If anybody on the call has, please do share it with me. It would be a unique thing for me to experience. I have not come across one of those.
Okay. Thank you.
Welcome, Sakshi. Right, so with that, thank you so much for your questions and interaction. I'll just continue. So confirmation of your NIPS results, you have two options, karyotyping in FISH and microarray. I would add the third option of QRT-PCR as well. You can do that, or you can even do MLPA, but those have their own limitations. KT FISH and microarray. Microarray is a better method for a lot of things. Of course, it's a little bit more expensive, but it gives you a lot more information for that minor bump in cost. It's a molecular test. You don't require cell culture, quite high resolution. You can check all your chromosomes for microdeletions, aneuploidies, and epigenetic changes like uniparental disomy. Uniparental disomy is a case where the child is getting two chromosomes from one parent rather than one chromosome from each of its parents. Even that can be picked up in a microarray. And always you have DNA remaining with us, and which we will keep by default for up to 2 years. If you want to do additional testing, let's say this pregnancy did not survive, but it was a precious pregnancy, and they're worried, they want to see, they say, okay, look, right now we lost the child, we are not interested in doing anything, we just want to take a break, recover. When we are planning for the next pregnancy, that time we'll think about doing testing, maybe down the line 6 months or a year. The DNA is still with us. Before they plan, they can actually do a test for the DNA, they can do an NGS, they can do a clinical whole exome, whatever is there. Try to find out if something is abnormal, check the parents, preconception, and then go ahead. So there's a lot of advantage in doing microarray based confirmatory testing. So to summarize, we have a broad range of tests from preconception all the way to prenatal. In preconception, we have the carrier screening, which is called couple sure. You can use the same setup for doing a donor screening. We have certain fertility panels which we are also rolling out and testing. In pre-implantation, we currently offer PGS. We are working very closely on developing our own PGD, and also we are looking at HLA typing for the embryo. We are also working on that. We are partnering with somebody for that. Prenatally, of course, we on the screening side we have NIPS and we have NIPS plus, but for precious pregnancies, two strongly recommended and indicated tests are NIPS Carrio and NIPS Carrio plus. Confirmatory testing, we offer KT FISH, we offer the microarray, Sanger and MLPA as required, and of course the NGS based exome testing. So what I would like to conclude on is a very interesting thing, and this has been my experience as long as I've been in the field of diagnostic genetic testing. This holds good. Help us, help you, help them. Very often what happens, we are able to help the next patient, the next family even better based on this partnership and our findings. So with that, I would like to say thank you very much. Thank you for your time, your patience, your interaction. And I would open up the floor to any additional questions or doubts. And I would like to conclude by saying thank you once again for taking time out on a Friday afternoon for this. And apologies to those who are not able to see my presentation. Unfortunately, I'm a little old school when it comes to certain technology. PGS, PGD, NGS, yes. But when it comes to Skype, I'm a bit old school. Thank you very much. So Dr. Arun, we would be emailing it to you. If you have shared your email ID with us, we'll email it to you. And Sharon, thank you for those kind words. Happy to be of help, Pumpy. Anything from your side also, please do let me know. Thank you, Dr. Deepa. Yes, definitely. Mitoscore, yeah. Any particular query you have, Ginny, on Mitoscore? Yeah, Mitoscore is a bit of a quandary for all of us. When you deal with euploid embryos, and how do you interpret Mitoscore, and how does that actually translate to implantation rates? I think there's a study from Manipal Hospital. Yeah, it is part of Ion Reporter. It is default built into Ion Reporter. Thank you, Dr. Tanu. We will be sharing that with you as well. So if there are no further doubts, I have already taken more time. Okay, yes, ma'am, absolutely. That is a wonderful suggestion. Challenging NGS data and how to align with practice. Absolutely, I would love to discuss that. Yes, that would be a wonderful session. And in fact, I would be talking to you one on one whether we could co-chair that session as well. So that would be really nice. That we are looking forward to doing something like that. So with that, I would happy to be of help, Dr. Priyanka. If there's anything to ask us, we would be happy to share that with you. So with that few words, I would like to say thank you all for taking time out of your day for attending this session and making it very interactive. I must say I really appreciate the interaction today. With that, I would conclude, and I wish you all a very nice weekend ahead. Bye.